Yeah, the middle button, honey. The middle button, yeah. Just keep clicking on it. Yes. All right.
Okay. So the key here to identify Charcot neuropathy to prevent early complication. I just want to show you this slides. أقول لنا الIT ناويين يعني يخبصوا البرزنتيشن بأي طريقة. So please take a picture or do whatever you want to do with this slide, because this is a piece of experience, you know, how to catch Charcot at early stages. So high suspicion of Charcot, if you don't have any open wound, please put Charcot at the top of your list. So order X-ray. If the X-ray is negative, do MRI. If the MRI, if you don't see diffuse bone marrow edema, and that means Charcot is less likely. If MRI is positive, then Charcot is most likely. So if you see positive finding in the X-rays, then you start the patient right away with offloading and total contact cast. Management of Charcot. So most of Charcot can be managed medically, and there is 25 to 30% of the cases, especially in rare foot and ankle Charcot, need surgical reconstruction. Sometimes the mid-foot Charcot we have to intervene surgically because medical treatment cannot heal the patient wound. So according to Eichenholz classification, in stage 0 and stage 1, we have to start immediate non-weight bearing and put the patient in a total contact cast. To be honest, total contact cast is the gold standard, but to be honest, I don't use it in my practice because our patients, they're very difficult. They soaked it with the water, they take a shower, and the patient come to your clinic with infection and tinea pedis. So I use a posterior splint or back slab with a sugar tank. My protocol to start the patient right away with the posterior splint and the sugar tank, and then I bring the patient 1 week to make sure there is no ulceration. I tell my patient, please offload your heel. Don't keep your heel in the bed because they come with the pressure ulcer on the heel. So after 1 week, I reevaluate the patient, and then after that, I tell them come after a month with X-ray, and in total 2 to 3 months, I keep them in a sugar tank with a posterior splint until I feel the temperature between both legs reach to the normal or less than 1. Once I feel the temperature less than 1, I put the patient in air cast, and I tell them to start gradually weight bearing until they feel confident with a walker assistant. This is the summary of the medical. So I keep the patient non-weight bearing for total 5 to 6 months. The new guidelines, you don't have to use Fosamax or alendronate or Prolia because it doesn't help for Charcot arthropathy. This is according to the 2023 International Diabetic Footwear Group recommendation. So in 5 to 6 months, I reevaluate the patient. If the foot is stable, so I will consider high neck shoes with the custom made insoles, and then I follow up the patient every 2 to 3 months with X-ray. If the foot is unstable, then we have to talk about the surgical intervention. So we try to avoid surgical intervention in Charcot because it's very complicated with a high risk of complications. When I discuss with my patient, I tell them you have 2 options. Either you go for reconstructive surgery or you lose your leg. Most of the time, the patient, they select to proceed with the limb salvage procedure. So before we proceed with any Charcot reconstruction, first you have to check for hemoglobin A1C, the cutoff for A1C 8 and below. The patient should have good vascularity. I don't need 3 vessels. 1 vessel is enough to heal Charcot arthropathy. And then we have to optimize the patient medically, and then we take the patient for surgery. Before the surgery, I have to discuss with the patient and family about pros and cons and a long period of non-weight bearing and the expectation after the surgery. So when do I consider Charcot versus amputation? Limb function preservation is the main key. Vascularity, glycemic control, cutoff 8 and below. Presence of wound and osteomyelitis. If the patient has extensive osteomyelitis, I will try to avoid Charcot reconstruction. Obesity, always there is risk of failure in obese patient. Medical comorbidities, patient with multiple comorbidities, end-stage renal disease or chronic kidney disease, always they have risk of delay bone healing or non-union. Younger patient lifestyle and economic status. If this patient is the one whose family depend on him, so I wouldn't consider reconstruction because he needs to stay off from his work for a long period of time. So I will share my experience here in Saudi Arabia. We started 2017 doing Charcot arthropathy. We did more than 80 cases of Charcot reconstruction with a high success rate, about 90%. I'm not saying that we're a hero, but at least we can save these cases which used in the past to have major amputation. So this patient, I will show you medical and surgical treatment. All of us, we see this wound, and Nusayba, she told you how to describe this wound. As we have to look to the wound, not just as a hole in the patient. We have to do a holistic approach. So in this patient, we start with the conservative treatment. We did a debridement, wound care, and offloading, and the patient achieved complete wound healing after 12 weeks. Remember, the key here to keep the patient free ulcer for a long time as much as you can. Do not let the patient go without diabetic shoes and custom-made insole to prevent the chance of recurrence. This case, again, same ulcers, midfoot ulcer. This patient, we tried conservative treatment but failed to close with the conservative treatment. We consider, always think simple about Charcot reconstruction. Don't go crazy, put screws and implant, and your surgery will fail. So you have to study your patient. This is patient obese, so we discussed the simple technique with her. We did debridement, exostectomy, Achilles tendon lengthening to correct the biomechanic. My friend Dr. Abdurrahman talked about biomechanical default for this type of patient. So we closed the wound primarily. So we did exostectomy and Achilles tendon lengthening, and this is how we do Achilles tendon lengthening. It's very simple procedure, but it will correct a lot of equinus deformity in diabetic patient. It will help you for a wound closure too. This is the patient 6 weeks after the surgery achieved complete wound healing. Another case, this patient with a 7-year-old wound, he was offered major amputation by most of the institutes, and he came to us at the last resort. So we discussed with the patient, and you can see his foot is completely dislocated with osteomyelitis. As you can see, there is destructive midfoot bone, and there is a previous surgery where they left the hardware inside the patient. So after a thorough discussion with the patient, he elected to proceed with a limb salvage procedure. So we did a reconstruction, we resect all the osteomyelitis, and we do arthrodesis. And this is the patient after 6 months from the surgery, and you can see how is the patient foot after reconstructive. And this patient, alhamdulillah, now is 3 years post-operative and he's walking on his foot. Please keep in your mind that you keep the patient in a protective shoes after your surgery. Again, this is young patient with Charcot arthropathy and osteomyelitis. He was offered major amputation, and this is the x-ray. Please, if you have patient with a Charcot and osteomyelitis and is stable, do not offer major amputation. Send him to higher center or specialized people before you consider major amputation. We put the patient in circular external fixator, and this is the patient. And this patient is 4 years post-operative, and he's walking and he's back to his life and doing his daily activity. This is the patient walking. Remember, this patient was offered major amputation. Imagine this patient life. Don't think prosthesis, it will help this patient. Prosthesis, the patient, they will develop contralateral ulcer, osteomyelitis, and then again, amputation of both lower extremities. Take home message. Sorry for the technical issues. Charcot foot and ankle arthropathy is complicated pathology with a risk of major amputation. Charcot neuropathy should be always suspected in every diabetic patient with a peripheral neuropathy, with red hot swollen. Educate patient and physician. That's why we are here, to educate our colleague to increase the awareness of Charcot arthropathy. Early detection is the key. It's not the surgery. Please detect Charcot at earlier stages. If you don't recognize it, please order MRI, and then after MRI, if you don't know how to manage it, please refer it to specialized physicians. Offloading is the key. As you know, in literature, total contact cast is the key and the gold standard, but we don't use it due to the nature of our patient. Most patients with a Charcot can be treated conservative. All of you guys can treat Charcot. You don't have to refer it to hani, so you can treat it in your centers. When do we consider surgery? if the patient non-braceable foot with a non-healing wound or with a chance with a recurrence rate of ulceration. This is what keeps us motivated. You know, when you see a patient with amputation and they were offered amputation, and you see all this patient back to their life and walking on their limbs. Thank you so much, and I hope you enjoy your day with my team. And please, can we take a picture with Professor Mahmoud Salah and Dr. Ahmed Saqar with our team?